Hello, everyone. This is Dr. Amigues, your friendly rheumatologist. Welcome to another Rheumatology 101 live. And today we're going to talk about positive ANA and what it means to have a positive ANA and how we approach this. Okay. So, very often in my practice, I will have patients who have had tests that were run and they come out freaked out because they have a positive ANA. And ANA is an anti-nuclear antibody. So it's the nucleus of the cell, and you're making an antibody against the nucleus of the cell. In general, in an immune system, what we know is that there is a balance between recognizing the self, what belongs to you, and recognizing what doesn't belong to you. And creating an antibody usually and for our body is to recognize something that doesn't belong there and that you want to basically get rid of. Okay, so it's kind of the signal for your immune system to say, hey, this is there, shouldn't be there. And ANA can be positive for many, many reasons. It can also be positive for no reason at all. It's kind of like a mole that you may have a mole that means that you've been putting yourself in the sun way too much time, and you'll see that you'll have moles. You can have a mole that goes and develops, you can develop a cancer out of that mole. Or you can have a totally benign mole that just says you have a mole. That's it. And we all have that. So I had a patient recently asking me, what do you do at Unabridged MD? What do you do? How do you approach a positive ANA? And this question comes so often that I decided to, one, we're going to talk about it, and two, we're going to actually create a website about it, positiveana.com. So we can learn all together. I can teach everyone. I can teach medical students, residents, fellows. I can teach also people who are not rheumatologists. I can teach patients as well. What is a positive ANA and in what categories of conditions they can be positive and what we do with them. Okay. So at Rheumatology on Unabridged MD, when I have a patient that has a positive ANA, the most important thing for me is to really listen to their story, to listen to the story and to ask the right question. Okay. So basically, if someone says, I have a positive ANA, at that point, I'm not actually looking at the numbers at all at that point, right? I'm just going to clinically understand what's going on because there might be a reason why that ANA was evaluated. Maybe one of the other physician or nurse practitioner or physician assistant thought, this sounds rheumatologic, let me check an ANA. And maybe because they are not specialists, they thought it was like they needed to check an ANA, but really they have an issue that has nothing to do with the ANA, but still is rheumatologic. So at Unabridged MD, the way I approach my patients is at this. I sit down, we sit down, and I'm going to let the patient tell their story. Like, since the last time you were perfect, what has happened? What other medical story do you have? What medication do you take? What allergies do you have? Do you have any family history of rheumatologic disorders? And then we go into what are your symptoms? What are you complaining of? Are you fatigued? Do you have joint pain? What type of joint pain it is? Do you have any rashes? Do you have sensitivity to the sun? Do you feel like your skin is tightening? Do you have Raynaud's phenomenon, which is a condition where you lose the blood flow in your fingers so they become white? Okay. Do you have any blurry vision, shortness of breath, chest pain? Do you have any change of your guts? Do you have blood in the stool, blood in the urine, foamy urine? Do you have any nerve issues? So either numbness or pain? Do you have any hair loss, patchy hair loss? All of those, oral ulcer, all of those are important because they are going to help us figure out if you have anything that sounds autoimmune. And the way I approach this is to really ask to, first of all, hear the story. Just have the patient talk and tell me what's happening. Sometimes it's going to be, you know, 1 year ago, I developed some joint pain kind of out of the blue or after an infection. The pain is worse in the morning. It's associated with morning stiffness, and there's some swelling of the joints, right? Then you're like, okay, that's an inflammatory arthritis. And then we look, is there any rash? Is there any hair loss? Is there any ulcers in your mouth or in your nose? Is there any urine changes? Is there shortness of breath, chest pain? In my head, if you're a rheumatology student or, a fellow or a resident, you're like, okay, well, I'm thinking lupus, right? But I can also think, okay, do you have suddenly Raynaud's phenomenon? So the loss of, like, it becomes very white, the loss of blood flow in your fingers in the cold or change of temperature. Do you have that? Do you have any GERD, reflux? That's new. Do you have shortness of breath? Do you have dry cough? Do you have skin changes where the skin is tightening? This is more like scleroderma. I'm putting a pause in case you're like trying to follow. Then there is also, do you have any dry mouth, dry eyes? Do you feel like you have pain all over your body? Do you have the inflammatory arthritis? Do you have any nerve issues? That, I'm thinking, Sjogren. And then there is also the cases of patients who have muscle weakness, not necessarily muscle pain, but muscle weakness. They cannot get up from the floor without using their hands, or they cannot get up from a chair without using their hands, and they feel like they cannot walk as much as well as they could before. Or, there's clearly like some issues with their muscle. That's, polymyositis. So inflammation of the muscle can cause that, and it's an autoimmune disorder. You also have issues with the lungs, like, is there shortness of breath, dry cough? Do you feel like you cannot walk without shortness of breath? Has this been just progressing throughout the years? Have you had repeated what would be called infection, but actually that may be a rheumatologic disorder? Right, that's antisynthetase syndrome. So we're thinking like that, right? Like, is this antisynthetase syndrome, which is in the category of dermatomyositis, but doesn't necessarily need to have skin issues or muscle issues. And right, like, and so we go like this in like basically looking at your whole body, basically looking at what's happening, right? And at first, I let the patient talk to me, tell me their story. Who better knows what's going on than our patients? No one. And I think the most important thing for me is to create an environment where my patients know that they have the time to talk. They have the time to tell the story. They have the time to tell me all of the symptoms that are going through. So we go there, and then I ask questions. Once the story is told, I ask them all of those questions, like the dry eyes, the dry mouth, the nerve pain, the numbness, the shortness of breath, the dry cough, the skin changes, the hair loss, the urine. And then I looked at the ANA. How was it done? Was it done with immunofluorescence, which is the one that I would look at? I don't do the direct one. Direct one are done in batch with ELISA, so they cost much less money, but they are not great because it's basically just telling us positive, negative. It doesn't really give us a titer. And then also it doesn't tell us which type of ANA it is, which is so important in rheumatology. So then we look at the ANA. What titer is it? The higher the titer, the more antibodies you have. So the less likely this is just a red herring and just something that we found. We would say in general, if you have a 1/40, that's considered negative. If you have a 1/80, that depending if it's homogeneous pattern, then we say it's okay. If it's more than 1/80, so double, every time you double, so 1/40 multiplied by 2, that's 1/80. Then you dilute it again, 1/160, dilute it again, 1/320, and so on, right? The more, right? So 1/320, it's still not that bad, but it is positive. And then you go to 6/40, etc. And that's becoming more and more positive and less likely to just be there. just, it's positive and it's fine. And also, I always say this, if it's speckled or nucleolar or centromere, that's the pattern that when we look at the blood, basically we can look at the fluorescence and we can look at the nucleolar because it's an antibody against the nucleolar, the nucleus of the cell, and we can look at how it looks under microscope, and it might look centromere, it might look ribonucleic, it might look speckled, or it might look beautifully homogeneous, right? Or just nucleolar, just the nucleolus. So that's the pattern, and they are all associated with different conditions that you have to think about, right? And so that's what's important. Is like what titer is it, and what pattern it is. And then I ask for more blood work. I think that when someone comes into a rheumatologist, they are asking for answers. Should I worry? Should I not worry? In general, I'm going to say, don't worry, because whether you have nothing, that's great. Whether you have something, we can take care of you. So no matter what, don't worry. But yeah, there might be an action plan that's different depending on what we find. And then we're going to order more blood work. So I'll order a panel of others antibodies. So for example, if I'm thinking lupus, I'm going to check a dsDNA. I'm going to check a Smith and RNP. I'm going to check a complement level, C3 and C4, because if they are done, that's another reason to wonder if this is lupus. And I'm going to order some other tests if I'm thinking that it's Sjogren. So we'll check SSA, SSB, and so on. In general, in rheumatology, I would say that we tend to order them almost all at once, just because it's actually more cost effective to do that. And then, you can be reassured if there is nothing, if everything is negative, you just have the ANA that's positive. That's pretty reassuring, as long as you have no symptoms. And as I always say, the symptoms are more important than a blood test. The symptoms are the most important thing. One, because you're bothered by them and we have to take care of them. And two, because you can still have an autoimmune disorder with negative ANA. But that's a different story, because in this case, you have a positive ANA, or we are in front of a patient with a positive ANA. From there, basically, we look at all of those antibodies. We also look at complications, the potential complications, right? So we do a baseline. How is your kidney function? How is your liver function? How is blood cell count? How are they? Do you have, any sort of electrophoresis abnormality, which is like how much you make immunoglobulin, or like protein, certain type of protein that are here to help you protect yourself against infection. We are looking at that. And then we look at the urine. That's very, very important, because sometimes that's the first sign of kidney issues. Okay. And then at the second visit, we go over everything we find, all of those results. Okay. And we get a really good sense of what's going on. And that's where we figure out what is this and how do we treat this. Sometimes I start treatment before, sometimes it's so obvious what's going on that you don't really need all of those blood work and you're just doing it as a baseline. Some other times you already have some blood work, so you have pretty good sense of what's going on. And then some other time you're like, well, no matter what, this is inflammatory arthritis. I need to treat it anyway, right? And so we can start treatment before. But in general, I would say it's a two-step process. The first one, really getting a sense of all of the symptoms of our patients, then asking the right question. Then second step is blood work, potentially x-rays of the joint, chest x-ray, chest x-ray to see if there's any fluid. If we need, we can do cardiac evaluation if needed be, pulmonary evaluation. We definitely need to check the kidneys. Okay. And then there's one thing I didn't mention, I started mentioning about it, but it's the fact that you need to also rule out other causes of positive ANA that are not autoimmune. And that's the hepatitis, infectious hepatitis, such as Hep C, that's pretty common. HIV can cause positive ANA. And then thyroid disorder, autoimmune thyroid disorder can cause a positive ANA. But you want to double check that you don't have any of those otherwise. So a lot of information. I hope you enjoyed this podcast, this live. If you did, please go to YouTube and subscribe to Rheumatology 101 Lives by Dr. Isabelle Amigues, Amigues. Share this with someone else that you think will enjoy this. And come back next week where we will talk about this more, and we'll talk about another rheumatology topic. In the meantime, I'm just going to say hi to everyone. Nicole, Candice, Oksanabi, Loska, Yekeke, Brian, Harriman, Amit, Nelly. Thank you so much for being here, for tuning in. If you are watching this as a replay, put hashtag replay. And until then, have a great week. I will see you next week. Take care.